In the study with Glofitamab, which is a CD20/CD3 bispecific antibody, we evaluated step-up dosing of Glofitamab with pretreatment with Obinutuzumab in patients with relapsed refractory mantle cell lymphoma. Specifically, being mantle cell lymphoma is a very heterogeneous disease, but patients post-BTK exposed have very poor outcomes in mantle cell lymphoma. Until recently, we had very limited options. As of right now, CAR-T is the really only effective option we have in this patient population, but it does have some adverse events that are concerning and limited to specialized centers that can give CAR-T. So in this study, we evaluated Glofitamab. Again, it is a bispecific that's a little bit different from some of the other ones on the market. It has a 2-to-1 binding epitope, so 2 binding areas for CD20 and 1 for CD3. To hopefully increase efficacy and targeting of T cells to the malignant B cell. So in this study, it evaluated giving Obinutuzumab, which is a CD20 antibody, on day -7, and then initially we did fixed dosing with Glofitamab at 0.6, 10 milligrams and 30 milligrams, which is a very small patient population, 3 patients. And then we proceeded to step-up dosing, where with the step-up dosing, you proceed with a very small dose of Glofitamab, and you increase the dose until you get to the final dose of 30 milligrams in an effort to reduce the incidence of the major side effect, which is cytokine release syndrome. Additionally, we continue with the Obinutuzumab as a pretreatment of day -7 to also hopefully decrease some of the receptor occupancy of Glofitamab in the early stages where we most likely would see CRS. As mantle cell lymphoma is uniquely situated for a higher clearance of Obinutuzumab, it's not thought that the Obinutuzumab would interfere with the efficacy of Glofitamab, because patients with mantle cell lymphoma clear Obinutuzumab very quickly. So once we get to the higher doses, we would expect that Glofitamab wouldn't have any sort of competition with Obinutuzumab. So what we saw in this patient population was a very high efficacy. As the majority of our patients were BTK inhibitor exposed, we did see efficacy rates range from 70 to 80% in this patient population, with CR rates from 60 to 70%. Specifically looking at comparison between BTK inhibitor exposed and naive, there wasn't a major difference, meaning that Glofitamab was effective in patients with relapsed refractory mantle cell lymphoma, irrespective of BTK inhibitor exposure. As far as the side effect profile of this treatment, we did see rates of CRS, but most of those were grade 1 to grade 2. They were typically short-lived and alleviated with use of preventative medications such as tocilizumab and acetaminophen if need be. As far as neurotoxicity, which is another concern of these T-cell directed therapies, there was only 1 incidence of a grade 1 neurotoxicity noted, which alleviated within 24 hours. So in this very small study, it's very promising data suggesting that Glofitamab potentially could be another viable option for patients with relapsed refractory mantle cell lymphoma who had been previously exposed to a BTK inhibitor. And because of the off-the-shelf availability of the agent, it does provide for more avenues for patients to get access to this medication, expanding outside of what has been, to this point, limited to academic sites within the U.S.